Good morning, everyone, and welcome to another health segment on colorectal cancer in African Americans with Dr. Christian Jackson. We're so glad that you were able to join us today, and please feel free to use the chat feature for any questions and comments that you may have. We will have time towards the end to review some of those questions. Now let's go ahead and open with a word of prayer. Let's bow our heads. Father God, we thank you so much for all that you have done for us. We thank you for bringing us here to get together in your presence. We thank you for the voice of Dr. Christian Jackson, for all the information that he is going to bring to us. Help us to hear him and be willing to follow what we are taught and apply it to our lives. We ask a special blessing for Dr. Jackson and his family, for his willingness to follow your leading and be with us today. Please bless everyone under the sound of my voice. In Jesus' name I pray, amen. So let me introduce to you Dr. Christian Jackson. He is a board-certified physician there at the VA hospital in Loma Linda. He comes from Albany, New York, and did his undergraduate at Northwestern University, where he majored in German studies. So we're hoping to hear something in German from him. He also did his he did his medical training at the University of Chicago Pritzker School of Medicine and his residency at Loyola University of Chicago. And his fellowship was completed at the Northwestern University. Currently, he is the Chief of Gastroenterology for the VA Loma Linda Healthcare Systems. He has been the Chief of Gastroenterology now for the past 12 years. He has authored over 40 peer-reviewed publications and has given multiple talks on health disparities in colorectal cancer. His focus of his research is health disparities and gastroenterology bleed-in. Let's welcome Christian Jackson. And he'll be joining me here soon. There he is. Hello.
Can you hear me?
I can hear you now.
Okay. Thank you very much for that very nice introduction. This is the first time that I've been asked to speak German during this presentation, so I will add that in at the end. So we'll include the German at the end. No, there's no problem there. Thank you very much. That was very nice. I'm going to talk today about colorectal cancer in African Americans and where we stand in 2021. My disclosures are as listed on the screen. So I wanted to start with, because this is a pretty broad topic, there's a lot to go through. And I want to start with the basics and then kind of work our way up, and then we'll get to questions. So my first point I want to talk about is just what is colorectal cancer. I think that's a good starting point. And first, we need to understand the anatomy of the colon and of the rectum and essentially where it's located. So essentially, this is in the lower half of your abdomen. This is a picture essentially looking at the colon. The colon is about 3 feet long, and the rectum is about, I would say, maybe 6 inches at most. And as you see here, this is a colonoscope, and we'll talk about this in a little bit. But essentially, what we do is when we use our colonoscope, we go in through the rectum and we move the colonoscope all the way to what's the beginning. So we really start at the end and which is the rectum, and we finish at the beginning. So it's a little bit counterintuitive, but essentially that's what happens. But this is essentially what just as a schematic of the colon and the rectum and what it sort of looks like when we perform colonoscopy. But it's located in the lower half of your abdomen. This is when we actually perform colonoscopy. This is what a normal colon looks like. As you can tell, it's pink. There are these folds that you see here, and this would be a perfect picture of a healthy colon. This is what we want to see. There's no bumps, there's no lumps called polyps. Obviously, there's no evidence of cancer. This is a normal, smooth, healthy appearing colon. So, what does your colon do? There actually are a number of very important functions of your colon. Now, going back from an evolutionary standpoint, the colon is one of the reasons why we're land animals. So the reason why we're not in the ocean is because we have the colon. The colon helps us reabsorb water. If we weren't able to reabsorb water, we'd have gills. So we're able to reabsorb water. We're also able to create waste, and there's probably somewhere between 500 million different species of bacteria that live in the colon, and they actually break food down and create waste. And to be frankly honest with you, there are some electrolytes that are able to be reabsorbed through the colon, and there's some nutrients that are able to be reabsorbed through the colon. And this is actually through the 500 million species of bacteria that live in the colon. So, and then the last thing that we know that it does, that it expels waste. So these are the main thing. But I think that the main point is from an evolutionary standpoint, this is the reason why we're land animals, and it actually has other functions that we're not that aware of. When we talk about colorectal cancer, there's actually a progression. And as you see here on the left, you see what's called normal mucosa, or was essentially the normal healthy colon that we saw earlier. And there are all of these different changes. And what you're seeing here in the different pictures are the changes. And the changes start from very subtle changes that you can only see with a microscope, and that's called an aberrant crypt focus. And we actually can see these now. I actually perform a procedure called endomicroscopy, where we can actually use a microscope through our scope, and we actually can look at what would look like a normal mucosa, and we actually can see these very, very small changes. Now, we don't do that often because it's a very involved procedure, but it can happen. And then as you see here, you see this progression from these microscopic changes now to these macroscopic changes. The first one is the early adenoma or polyp. And then you see the progression onto cancer. Now, all these funny words are at the top here. These are essentially words that are pointing to genes. And what happens is that there are multiple different mutations that have to occur from the normal mucosa that move on to what's called invasive cancer. And you have to have changes in these genes in order to develop cancer. As you can see here, it's not an easy process, but it can happen. We can actually influence, and this is part of the healthy lifestyle, we can actually influence some of these mutations. Some of these mutations are going to occur no matter what. And that can be because of age, that can be because if you have a genetic abnormality, family history. There are lots of things, but there are other things that you can do that can somewhat influence this. And this comes from healthy eating. This comes from exercise. And this comes from actually going ahead and getting screened and having a colonoscopy. Because what happens is if we take out, like, for example, you see the early adenoma or the late adenoma, if we remove that, well, now it's gone. And so now you essentially revert back to the normal mucosa. So we're actually able to interrupt this process. This process you see right here occurs if nothing happens. If we just leave you alone and just let this go, then in about 5% of folks, this will happen. But if we interrupt the process and take out that early adenoma or take out that late adenoma, then we prevent that progression, unfortunately, to invasive cancer. So this is an important slide because it shows the progression from the normal mucosa or normal healthy colon to the colon cancer. And this is just a picture of what colon cancer looks like. Obviously, you can see that it can either stay in one part or actually can become circumferential, which you see on the right. And as you can tell, when you look at this picture, this is clearly abnormal. And this is somebody who unfortunately was diagnosed with colon cancer. And when we look at the statistics for 2018, it's essentially the same for 2019. I did not include 2020 and 2021 because the numbers are going to be skewed because of COVID. We will talk about that a little bit later. But essentially, in terms of new cases of colon cancer and rectal cancer, you're talking somewhere around a little less than 100,000 cases of colon cancer. It's going to be a little less than 45,000 cases of rectal cancer, and there's about 50,000 deaths. This number for deaths has stayed about the same for years, so it's around 50,000 or so. It has gone down, but it stayed about the same, and it's going to be a little bit less. But again, that's skewed because of COVID. Like I said, we'll talk about that later. But I wanted to give you statistics. These are essentially the pre-COVID statistics for colorectal cancer. When we think about colorectal cancer in the United States, it's the third most commonly diagnosed cancer in the United States. It's a little bit, it used to be around 5%, it used to be a little bit more than 5% actually, and it was 5% for a while. Now it's a little bit less than 5%. And it's a little bit higher chance for developing colorectal cancer among average risk. When I say average risk, men, these are men and women who do not have a family history or a genetic syndrome that would predispose them to developing colorectal cancer. It's going to be a little bit less for women. It's going to be about a 4.4% chance for developing colorectal cancer among average risk women in the United States. When we actually diagnose colorectal cancer, it's the third leading cause of cancer-related death among men and women. The numbers are fairly good if we catch it early, and we'll talk about this a little bit later, but it's about a 90% chance of 5-year survival if the cancer is localized. And what does localized mean? Localized means it's within the lining of the colon. It hasn't spread. And so when we talk about spread means spreading into the lymph nodes, into the blood vessels, and when it breaks through the lining of the colon, it can get into the blood vessels, it can get into the lymph system, get into the lymph nodes, and once it does that, then it can spread. So if it's localized, that's if we do have the misfortune of being diagnosed with colorectal cancer, and it's localized to the lining, and yes, the person being alive in 5 years around 90%, maybe a little bit higher than that now. In terms of regional disease, and this is disease that's just at the lymph nodes. It hasn't spread anywhere else, and it's about a 70% 5-year survival for regional disease. And then obviously, if it's spread, and when we mean spread, it's gone through the blood vessels into the lymph nodes and now gone to other organs like the liver, then the 5-year survival trails off considerably, and now you're at about a 10% 5-year survival, and that's for metastatic disease. And so this is again points towards screening, where if we, like going back to the earlier slide, is we want to catch the polyp, or what the previous screen said, early adenoma. We want to catch that and interrupt that progression. If we have the misfortune of diagnosing colorectal cancer, then we want to be able to catch it early. Screening should, for the most part, be able to help us catch early cancers. That's a localized cancer, which is going to give us the best chance for survival. So when we look, these are just graphs just to kind of give you a understanding of where colorectal cancer lies amongst males and females in the United States. Obviously, amongst men, it's in terms of incidence or cancers that we diagnose. Prostate cancer is going to be number 1. Lung cancer is number 2. And these numbers have not changed at all over the past. This is since 1975. When we look at females, breast cancer is number 1. And what's interestingly enough is that cancers of the lung and bronchus actually match that of men. So lung cancer now matches, that's the second most common cancer diagnosed in females, mainly because of the uptick of smoking, which again is another factor that can interrupt the progression. We talked about diet. I talked about diet just briefly, but smoking is a big one. So eliminating smoking, that is not only cigarette smoking, cigar smoking, tobacco smoking, all of that, if that can be stopped, that clearly is a risk factor. But with the increase in smoking amongst women, yes, that's why lung cancer is number 2, and colorectal cancer is number 3. And as you see, in both males and females, colorectal cancer is decreasing amongst both sexes. When we look at mortality, again, mortality is going down for both males and females. It's going down much more rapidly for females than it is for males. We're going to get into that just a little bit. There's a number of reasons for this, but mainly one of them is the fact that females in general are more apt to access the healthcare system more so than men. Men are usually more resistant to accessing the healthcare system. Like, for example, my father was absolutely adamantly against having a colonoscopy. And he and I had to have major discussions. And finally, he was able to do it. Now he's fine with doing them. But initially, it took a long time for him to be convinced. And this is a guy who's a PhD from Northwestern. He was former principal of my old high school. This is an intellectual, and it still took a lot of convincing to get him to have a colonoscopy. So that's part of it. That's not the whole reason. That's just an example. And again, not to speak ill of my father. I love him dearly, but it's just an example of some of the reason for the difference in terms of difference in mortality. I just wanted to talk about the regions in California, and there's actually a point to this. Because the California Cancer Registry is a registry which involves the entire state. So the entire state of California is tracked. So every single person within the state is tracked. And they're actually in every single cancer outside of the VA system is actually tracked through the entire state, which is pretty amazing in itself. And so we're actually able to track those cancers that are diagnosed throughout the state, including and it goes by county, and this includes San Bernardino, Riverside County. And so what we saw here were national statistics, and I just wanted to, this is an older graph here, but essentially shows you the trends, that the trends within San Bernardino County, which is Region 5, essentially mirror that of the nation, where you see where cancers of the colon and rectum are going down, both in males and females. And what we're seeing is similar to what we're seeing in throughout the nation. And the same thing, mortality rates. Mortality rates are going down for both males and females in San Bernardino and Riverside County, or otherwise, in Empire. I know, sorry about this graph; it's a little bit blurry, but this is a very important graph, because we talked about the incidence of colorectal cancer going down for males and females, and it is. However, when you look at race, again, it's going down, but the rate of decline is not as steep for African Americans as it is for Caucasians, and that is an area of concern. So this is a graph that shows this is national data with the SEER registry, and again, this is the incidence of colorectal cancer. The incidence is going down, but not the same rate as it is for, and there's actually a significant separation for African Americans versus Caucasians, so that's concerning. And then when you look at mortality rate, again, the gap is even widened. Yes, the mortality rate is going down, but it's not going down at the same rate as it is for whites. So that is, and this has stayed the same. As you see here, the break happened in about 1985 or so, and so that's kind of interesting. And I know some people may have some questions about that. I have some thoughts about that, but nevertheless. The rate has not been commensurate. The rate of decline has not been commensurate for African Americans as it is for whites. When we look at incidence rates for California in terms of colorectal cancer, San Bernardino County is at the highest. It's at the highest in the state, and Riverside is number 2. So clearly, it's an issue. The incident rate for colorectal cancer is problematic in San Bernardino County, and it is for Riverside County. And if you look at mortality rates, again, we're at the top in the state. This is not where we want to be, but nevertheless, this is where we are. both San Bernardino and Riverside County. So essentially, so effectively, the Inland Empire has the highest rates of incidence and highest rates of mortality in the state of California. I wanted to show this graph. It's a little bit of older graph, and when I've and this is essentially it's stayed the same. But what I found interesting about this graph is that when we look at mortality rates through when at the Inland Empire, and I look at it nationally, it mirrors that of areas that are at higher risk. And what's at higher, and what are the areas that are higher risk? Areas that are higher risk are those areas, as you can see, in the South. So those are areas of clearly higher risk. And there's a lot of reasons for that, and we can talk about that a little bit later. But the other thing which was striking to me is that we were not that far off, not only from the South, but also not that far off from Chicago. And so, again, why are those trends, and why are those trends in mortality? Why? I mean, we're a little bit less, but again, why are these trends similar to the South? Why are these trends to big cities? This is clearly concerning in an area, but again, I believe the last time I looked, we're talking about both San Bernardino and Riverside County have a total population of about 5 million people. So why are these rates similar to those in the other high risk areas? And that's something that that we need to think about. But I wanted to show you this graph to kind of give you a broad perspective of what's going on, not only within the state, but also what's happening nationally. When we look at, I included our own data at the VA, and I want to include that because everyone believes that the VA is an equal access institution, which it is. The VA, we do not, insurance does not play a role at the VA. There are some other issues in terms of patients who are once they come in terms of their eligibility status, and that may influence a copay. But there's no insurance. There's no insurance at the VA. But nevertheless, there are disparities within the VA, and this is supposed to be an equal access system. That's what the VA is known. It's known as, this is equal access. This is our version of open access healthcare, similar to what you see in other countries, mainly the former Western Europe. And nevertheless, you still see a disparity within stages. So, like, for example, when you look at African Americans, those who are diagnosed with stage 4 cancer is at a much higher percentage than Caucasians and Hispanics, and that is a cause for concern in an institution which is equal access. So that's something that I wanted to show. That's not because the data that I was showing before was non-VA data, and this is now this is VA data. And we look at and then I just put a quick slide in here, just looking at socioeconomic status. And again, those patients who are more likely to be diagnosed higher stage are of more lower socioeconomic status versus those who are of higher socioeconomic status. So getting back to why we screen for colorectal cancer, one of the main reasons why we screen for colorectal cancer is colorectal cancer is an ideal target population to screen. And it's going to affect about 5% of the population of adults. So this is a disease that we want to screen for because it's prevalent. It can be detected hopefully at an early stage, and can be treated at an asymptomatic stage, which leads to reduced cancer mortality. And there's several studies that have shown mortality benefit from screening. Right now, the VA is doing one of the largest studies that has ever been done the largest study that's ever been done to actually determine what are one of the factors of mortality from colorectal cancer, and does colonoscopy versus stool testing, we'll talk about that in a little bit, is beneficial in terms of improving mortality. And so clearly we do have a lot of indirect evidence that shows that there's a mortality benefit. Now we're in the process of actually proving which one. And so how do we define screening? Screening is essentially a strategy which is used to investigate for the presence of a disease where the populations which population is at risk for in a healthy individual who does not have evidence of disease. So if you are someone who's healthy and you have a prevalent disease within the population that you live in, we'd like to screen to determine, are you at risk? And we want to be able to catch if there is of misfortune, we want to be able to catch it in an early stage so we can be able to treat it. This is why we want to screen. And so how effective has it been? Well, as we remember back from that graph, there's been decline in mortality or death that started in 1985. And what's interesting is that screening colonoscopy was covered by Medicare and Medicaid beneficiaries starting in 2001. You actually saw an uptick in terms of the use of colonoscopy starting about the late 1990s. And so when we look at 2001 to 2010, there was actually a decline in the incidence of colorectal cancer. And that decline was most likely seen in those of Medicare, between the ages 50 to 75. And it was thought to be secondary to an increase in colorectal cancer screening rates. It was 19% in 2001, and it's 55%, which is still very low in 2010. But I don't think that is the entire reason for why that's the case. I think there are lots of other reasons, and that's what this slide shows. So what we noticed is, and so if you look at that graph, the graph shows that from 1975, we're actually starting to see a decrease in mortality. And so why is that? Well, cancer therapy became better, chemotherapy became more effective. The risk profiles were changing. Why? We were working out more. We were eating healthier. We actually eradicated, and this is a kind of a question mark of, there's an organism that lives in our body called Helicobacter pylori. That's a bacteria that lives in our stomach. There's actually some thought that this could play a role in the fact that we've eradicated this to a significant degree in this country, may have played a role. In smoking, there's been a tremendous decline in smoking in the country. It's not completely eradicated, but clearly is declined a lot. And that could be the reason. Before very aggressive screening strategies, especially using colonoscopy, why we saw a decline in colorectal cancer from 1975 to 2001. But then when you look from 2001 to present, again, it's more than likely the same. The biggest issue is the screening programs, and that's what you don't see from 1975 to 2001. Now we have, and we'll talk about this a little bit, we have so many different forms of screening that this plays a very important role in terms of changing the risk profile for developing colorectal cancer. So how effective has it been? There's about a 55% increase in colorectal cancer screening. Again, only half of those people who are eligible for colorectal cancer screening are being screened, and who aren't being screened at the rates that they should be screened at. And again, that's African Americans, American Indians, or Native Americans and Alaskan Natives, people of low socioeconomic status, to a certain degree, people of Hispanic ethnicity. And we look at this, higher rates of colorectal cancer incidence and mortality can be seen in these groups when compared to the general population and Caucasians. And again, has colorectal cancer screening been effective for everyone? And that's a big question. And so when we think of colorectal cancer screening in this country, this is who we think of. We think of Katie Couric. That's if people are attuned to this and aware of this, this is who we think of. We think of Katie Couric, and it's what's called the Katie Couric effect. So in 2000, Katie Couric's husband was unfortunately diagnosed and died from colorectal cancer. And she famously, in 2000, underwent a colonoscopy on live TV, which was kind of interesting. It was unsedated. And if you notice that she was grimacing because it was an unsedated colonoscopy, which is a little bit difficult, but she did it. But nevertheless, this is what's the effect. That's what people in the United States, if they're tuned understanding colorectal cancer, that's what they think of. However, this is the other face of colorectal cancer. And to me, this is the most important face of colorectal cancer. And this is the young African-American male. This group is the highest risk for developing colorectal cancer amongst anybody. And these are two gentlemen, if you may recognize them. On the left is on the right is Darryl Strawberry, a famous Major League Baseball player. On the left is Eric Davis, another famous Major League Baseball player. They were both diagnosed without any real known family history of colorectal cancer, and they were diagnosed at young ages. And so this is, to me, the most important phase of colorectal cancer, and this is what we need to know. And I actually wrote an editorial several years ago, and I included this in my editorial because when we talk about colorectal cancer screening, it does matter if you're Black or white. It does matter if you're African American. It does mean something. And this is the face that we have to be aware of. And this is the other face of colorectal cancer that I think that we forget about. We forget about demographics, and especially when it comes to delayed stage. And this is a study that we did several years ago. And in California, one of the biggest indicators of delayed stage or late metastatic disease are those folks who are of low socioeconomic status. And so when I put this picture in here to show that here is an African-American veteran who's outside, he's homeless. And this is another face of colorectal cancer, which is extraordinarily important. And this is one we have to know about and we have to understand, and needs to have the same type of effect as we saw with Darryl Strawberry and Eric Davis, along with Katie Couric. So I just wanted to bring these examples because these are the examples that need to be emphasized just as much as the others. So when we look at screening based on income, this goes back to the study that was published several years ago. When we look at screening, yes. When we look at screening adults and we look at income, yes. People who earn more are more likely to be screened. And again, that is, I don't think that's, it's not where it should be for any of the groups, but clearly there's an increase. The more resource you have, the more likely to be screened. I don't think that is in question. And then we look at educational level and screening. Yes, the more education that you have, the more likely you are to be screened. Again, when you look at the screening percentage, it's still very low, and it should be higher in all categories than what it is. But clearly, income and educational level play a role. Now, when we look at African Americans versus other groups, and we look at educational status, yes, it plays a role, and it plays a significant role. And if you noticed, irrespective of degree, you still have a disparity amongst African Americans versus every other group. So that's another cause of concern. So those African Americans who are educated and have resources, they're still at risk compared to everybody else. And so again, these are all red flags, causes for concern, causes for reasons to be for us to stop and pause. And we need to have emphasis on these areas, because we should not have such disparities, especially, well, prior to COVID, and we'll get into COVID because COVID has truly changed the face of everything. But nevertheless, we shouldn't have these disparities at this time in this country, in my estimation. I wanted to talk about our experience within the VA. One of the things, and I wanted to bring this up because, again, the VA is seen as equal access. Our patients are diagnosed earlier in comparison to those patients within the national registry. There's a higher percentage with patients with localized disease versus those with distance disease. And I want to kind of put a caveat to that, is that that's the national VA data, but our data in the Inland Empire at Loma Linda does not necessarily reflect that per se. But when you look at it in general, you have to, on the other hand, it's an equal opportunity, equal access institution. And so there are robust screening practices. There are screening reminders. There's lots of quality improvement initiatives that are going on. There's patient navigation. But again, like I said, this has not been a complete success story. From last I looked, is that African Americans, even though they're still higher in terms of incidence and mortality in general than the United States, and happens in the VA system, it's still lower in the VA system than it is nationally, but it's still higher within the VA system. So like I said, this is not a complete success story. And this is evident by a very nice study that was done at the VA, at the Los Angeles VA, where they noted that in terms of screening, and again, equal access system, that African Americans, still there was a gap in terms of screening rates amongst African Americans versus non-African Americans, primarily white. So again, these even within equal opportunity system institutions, there's still gross abnormalities and discrepancies. So does colorectal cancer screening work? I believe it's effective. There is randomized controlled data that shows the fecal test, which is essentially putting not the best thing to talk about early in the morning, but again, your stool on a card, and we hand the card in. That fecal occult testing, stool testing does work. It is shown to reduce mortality, no question about it. And there's observational and cross-sectional data that show that colonoscopy reduces mortality. The big study within the VA is going to prove that. Is going to show whether is it the stool test, is it colonoscopy, are they effective in terms of reducing colorectal cancer? But we're still not able to reach groups who are at high risk. I've just shown multiple examples of showing that African Americans are at high risk, even in equal access centers, and we're still at higher risk. Why is that the case? And so that's one thing that we need to continue to work at. And the next question is what's the best method to screen for colorectal cancer? But before we get to that, I wanted to talk about, does screening work? Well, yes, but the data is conflicting on what screening modality to offer African Americans. African Americans prefer colonoscopy, but may not complete colonoscopy, which means actually showing up and doing the test. African Americans may be less likely to choose fecal-based tests, but be more likely to complete them. There has been very nice studies that have been done at Mount Sinai in New York on patient navigation. That has been very effective. And the consensus is to offer multiple screening modalities, in order to determine. And essentially what this means is having a conversation with your physician. The physician should be having a conversation with the patient and offering multiple modalities, figuring out what are the fears, what are the issues, what are the barriers, and working through to figure out what's the best way to get this done. And there's actually data to show that that's been a problem. Talking to the physician, it's been a problem. And so I know there's been some efforts within the gastroenterology societies in order to address this. We need to be much more robust about it. But nevertheless, if you're going to offer multiple screening modalities, which we need to do, you need to have a conversation with the patient in order to do that. And like I said, physicians need to be more proactive in terms of offering colorectal cancer screening. African Americans are less likely to receive physician recommendation. That's a problem. Same thing with those who are low socioeconomic status. Physicians also need to be given the tools and resources to offer colorectal cancer screening. And there's actually we actually have a reminder system within the VA, and that actually is shown to be very helpful. So that is something which I think with the new computerized based medical record systems that are going in, they're actually putting in those reminder systems in order to help physicians do that. But I think the first and foremost is you have to be proactive. And so
we have just about 10 minutes left.
Got it.
We like to get to the COVID. Yes.
Yes, no problem. Yeah, we're going to get to COVID. So, and what's the best screening process? You can see here, engaging the subject. That's number one. If you can't engage the subject, the rest of this isn't going to work. And so you have to engage the subject to talk about the screening test. And then it has colonoscopy here, but nevertheless, it's engaging the subject to talk about a screening test, whatever that screening test may be, whether it's fecal testing, whether it's colonoscopy, whether it's CT colonography, whatever it may be. That's where you want to be able to go, where the patient's going to accept, and then you go on, and then you go for treatment and follow-up and surveillance. But like I said before, the most important is engaging the subject. Is there a dominant strategy for colorectal cancer screening? No. And as you see here, these are the different societies, medical societies here, and you see all of the different strategies that they have, multiple different strategies. So this is still a work in progress, and this is why you need to have a fruitful and robust discussion with your physician to determine which is the best for you. And as you see here, these are all the different colorectal cancer screening strategies, and you can they're all over the place. And I thought this board here with all of these different menu options is similar to what you see here with all the different strategies. I mean, within all the different societies, you have somewhere between 18, 19 different strategies, not different strategies, but strategies that are endorsed by each and every one of the societies. And so the reason I put this slide in is because one of the things that we are trying to do in healthcare now is what's called precision-based medicine, which means we're trying to tailor therapy which is going to be best for the patient, not just throwing out a bunch of things and say, well, I talked to the patient, but actually figuring out what is the best modality that's going to work with the patient. What's the patient going to follow through with? And the reason why I put this slide in is because this is a 747 jet landing over a beach onto a runway, which is right next to the beach. And so you have to be very accurate in landing this plane. And that's where we want to be able to get when we are offering screening and encouraging screening and getting people to follow up with colonoscopy. This is what we want. We want to be accurate because we want to be addressing the needs and the concerns of patients. And so what's the best way to screen? Like I said, there's multiple options, there's multiple choices, and the options need to be based on a number of factors. That's the population you're dealing with, the capacity to do colonoscopy, the availability of the test, which test is actually going to be done.
Is Dr. Jackson frozen there? Is it just okay? Well, we'll wait for Dr. Jackson to pop back in here and finish. Oh, here he comes. He's back with us. We have 2 more minutes left, Dr. Jackson.
Okay. So main thing is, as I move along here is again, when it comes to screening and health, we want to reduce the burden, and we want to find the best mode of screening for the patients that we're taking care of. And these are all the ways that when it comes to non-invasive screening, that we want to go ahead and address. The last thing I wanted to talk about is COVID and colorectal cancer screening. And COVID has had a significant impact among African Americans in general. And not only has it been secondary to COVID, but it's also been secondary to non-COVID related diseases that have not been addressed or taken care of during the time of COVID. And one thing that has happened is that there's been a marked reduction in clinical visits, and there's been reduced capacity means for colorectal cancer screening. There's actually been a significant drop in screening. Some reports say up to 90%. And so I know, at least in this part of California, it's kind of been varied, but I know that there has been a response to come back to going back to getting people back into the office, either virtually or even in person. But nevertheless, 2020 was for an innumerable number of reasons a very significant had a very significant negative impact, and one of those impacts was colorectal cancer screening, and it definitely hit the African American community very, very adversely. And now I know there are plans to help come back from that. But nevertheless, there has been a significant impact. I know there are probably going to be questions about this, and so what I will do is I'm just going to make this is just a conclusion. My last slide here. This is a picture of Cook County, and essentially, just to give a very brief story, when I was a fellow many years, about 15, 16 years ago, Cook County lost its ability to screen. And Cook County serves a very high number of African Americans. And one of the things that we did was we actually built a screening program, which actually exists today after all these years, which is a multifaceted, multimodal screening program, which is focused on providing multiple modalities and having a discussion with the patient to figure out which is the best mode for screening. And so I just wanted to bring that up. That's my last slide. So I needed to say something in German, and so I'll do that right now. So ich bin ganz dankbar, dass ich eine Präsentation zu deiner Kirche über Colorectal Cancer Screening has begeben. So I just said I'm very thankful to give a talk to the church on means for colorectal cancer screening. So that's a quick sentence in German. That's my last slide. I think we're about 42 minutes, and so I will end there.
Oh, thank you so much, Dr. Jackson. That was great to hear that. We so appreciated your coming. We have several questions, and one is, what is the prevention for colorectal cancer? I understand that 30 grams of fiber a day and aerobic exercise, smoking cessation. Are these the prevention methods for colon cancer?
Yes, and that's where you see when we look at that graph from where we start to see the decline in colorectal cancer. Yes, so fiber over the long stretch can be helpful. When I mean long stretch, this means over years. So consistent intake of fiber over years will be helpful. Exercise, no question about it. I think there's a role. It hasn't necessarily been proven. We don't advocate it, but I think there is a role for vitamin D. I don't necessarily say go out and take 20,000 units of vitamin D every single day, and that's going to reduce your chance of colorectal cancer. But nevertheless, getting outside, exercising, that clearly is going to reduce your chances. People who are obese, they are at higher risk for developing colorectal cancer versus those who are non-obese. So when you look at that, that plays a role. And if you look at patients who exercise, that necessarily hasn't been proven, but nevertheless, patients who exercise, they're most likely to have other healthy habits. They're probably less likely to smoke. I don't think someone who's going to run 4 miles a day wants to smoke. And smoking is a major risk factor for developing colorectal cancer. So you see the declines in smoking, increase in exercise, improving our diet. Definitely, these are the reasons why the decline has occurred.
Another question is, did the age of screening drop from 50 to 45? Are we asking our 45-year-old men to start asking for their colorectal screening?
Yes. So years ago, the American College of Gastroenterology was the only society that advocated 45, and now we're seeing an uptick in colorectal cancer, and even those adenomas, those small polyps that we saw, are more prevalent in those who are younger. We're not entirely sure why. There are many reasons for it. But yes, the screening age has dropped. I advocate the screening age to be 45. And that's, I think, or should be. It's still somewhat debatable. Definitely among African Americans, the screening age should be 45, without question. I think African Americans, Native Americans, definitely should have a screening age of 45. And so that's my take. I know that's somewhat still controversial, but the more and more societies that are advocating that. So I advocate that as well.
And then we have another question from Maria. Doctor, how many bowel movements should a person have a day?
I think that's a great question. I think that it's what you feel comfortable with. I think that health, yeah, yes, health begins in the colon or death. That's very true. Um, it's where you feel comfortable and where you feel good. If I wouldn't necessarily, if you feel fine at having one bowel movement a day and you don't have the necessarily, you don't have the symptoms of constipation or abdominal pain or any of that, or any of those symptoms, and you feel fine, then that's what you should do. If you feel better at 2 times a day or sometimes 3 times a day, then that's okay. But I think if you're having more than, I would say, 2 to 3 bowel movements a day, that's somewhat of a concern. It doesn't necessarily say you have colorectal cancer, but I think trying to target, I need to have this many a day, I think that in itself causes stress. It's what you feel best with. Where do you feel best? If it's once a day, great. If it's 2 to 3 times a day, great.
So at least the minimum is once a day, right?
I would say once a day. I mean, for most people, but nevertheless, there are some people that have it every other day and they feel just fine. And I never would say to a patient, no, you need to have it every single day. If they come and tell me, hey, Dr. Jackson, I feel fine having it every other day. So I
Okay.
think what feels best for you. Where do you not feel constipated? Where do you feel relieved? Where do you feel, for example, after you have a bowel movement, do you feel relieved? Do you feel better? And that's how you feel. If you feel better after that, that's how you should feel.
Oh, good. And then our last question is a two-part question coming from Francis Parker regarding why are African American men being screened earlier, and how can we start the conversations with them to encourage them to be screened earlier?
Yeah, great question. So I think number one is the word has got to get out, and that goes back to the Katie Couric effect, right? So there needs to be a push to get the word out that young African American men are at the highest risk amongst anybody else in this country. That's number one. Number two is it also the church. The church plays an enormously important role in the African American community. There's actually, speaking of my father, he actually wrote a field essay back in the early 70s about the role of the church in healthcare, and this has been well documented. And so the church being a means to get the word out and provide and to continue to provide a robust message to African American men to get them screened and continually bring it up. And I think we need to give means for African American men, because there are real concerns about colorectal cancer screening, performing colonoscopy amongst African American men. I have heard many of them, and they are real. And there are fears, and those fears have to be addressed. And they're not silly. We have to be able to have an upfront, realistic conversation, and it needs to get out nationally. It needs to get out from the county standpoint. It needs to get out from the state standpoint. It needs to get out from every way possible. This has to be pushed. And it's going to be hard now because of COVID, but we have to be able to do that because it's essential. Because if you look at those graphs, even though there's been a decline in mortality, there's still a huge gap. There's still a huge gap. After all of this, there's still a huge gap, which means the next step is we have to get African Americans involved, especially African American men involved in research, which I know that's in itself is a difficult area, which that's a talk in itself, and I'm not going to be able to do it justice in 5 seconds. But we have to get African Americans, especially men, involved in more research in colorectal cancer. It's the whole gamut. You have to be involved in every stage of this, but we got to be able to be proactive, be positive, and be able to push this.
Oh, good. One last question there about the fears. We are all more afraid of the pain of the colonoscopy. I understand that now you put them completely to sleep for a colonoscopy. Is this right?
What? Yeah, not completely asleep, but
Oh,
very sleepy. I think I would say this. I've done thousands of colonoscopies, thousands. And 90 8% of them. If the patient has pain, it is very transient, and we're able to find ways to ameliorate the pain. In 98% of those cases where the patient had pain, they didn't even remember the fact they had pain. So we give medications. So we give medications like Versed, which is midazolam, which is an amnestic. You forget. The agents we give are very powerful. Fentanyl, I think that's been heard. That we've been talking about fentanyl. We give that from an IV standpoint. You can request, and again, that you'd like to see if you'd like to be under the care of an anesthesiologist to give medications like propofol or other medications to help with your sleep. But pain, years ago, pain was somewhat of an issue, but right now, that's really not. If I look at the overwhelming, and I mean thousands of cases, pain has not been an issue. It really hasn't. We're able to use the medications we're able to use are very good. They're very effective. We're able to use different techniques with the colonoscope. These colonoscopes are built differently. There's so many factors that make pain not a major issue. But yes, people are concerned about it. There's no question, and pain's real. But the overwhelming number of cases, pain has not been the issue, or has not been an issue whatsoever. And if there is an issue, we stop, and then when we stop, we put the care. We then reschedule and have the patient be done on the care of an anesthesiologist. And in those cases, almost 100% of those cases, not 100%, but I would say 99% of those cases, the patient does very well and doesn't have any pain. So I mean, pain there are ways to deal with it, and it's not a major issue.
Excellent. Thank you so much, Dr. Jackson. I know Hattie, Maria, Francis Parker, and Victoria were so happy. They put that in the chat that they were so happy to have you here, and they thank you for your time. It was very informative with this. So our takeaways, it seems that if caught early, we have a 90% of a 5-year survival rate, past the 5 years, but at least definitely on those 5 years. And we really need to push our African American men to get screened, as the mortality rates are just too high in Riverside and San Bernardino counties. So we really want to encourage them, our husbands, our brothers, boyfriends, whatever, every African male that you see walking, to get their screening done, because it is not necessary to die from colorectal cancer if caught early. We thank you so much again, Dr. Jackson. We'll go ahead and close out for now, and blessings, everyone.